Okay, are we ready to start? Welcome, everybody. Okay? Yeah, okay. Well, I'm so pleased you're all here, and welcome to this very special Nursing History Symposium. My name is Gertie Boschma, and I'm a professor and co-lead of the Consortium for Nursing History Inquiry at the School of Nursing at UBC in Vancouver, where we are. And also welcome to everybody who is with us from a distance online. It's my great pleasure to welcome you to this 2022 Nursing History Symposium, which will focus on public health and pandemic caring in context. Welcome to the people in the room, as I said, and also welcome to the many of you who are joining virtually. It's our first time that we gather in this hybrid format, and we are happy that you all can join. We are gathered here physically at the Cecil Green Park House on the UBCV campus. And so to start the symposium, I would first like to respectfully acknowledge the land on which we gather. Physically, we are gathering at the Cecil Green Park House at the UBC campus, which is on the traditional, ancestral, and unceded territories of the Coast Salish people, and particularly the Musqueam First Nation. The School of Nursing is also located on this land, and virtually we join from many different places. We are privileged to be here and to be able to learn together on this land and in this space. And then today's symposium is special for a number of reasons. First, we are very pleased, and you may not know or you may not realize, but we celebrate that the Consortium for the Nursing History Inquiry, which is host to today's symposium, actually exists now for 10 years. It has been in existence at the UBC School of Nursing since 2012 and is now a full decade old. We are very much looking forward to move this consortium forward in its next decade. I would like to acknowledge the consortium's leadership and steering committee members, Dr. Lydia Wittenbroek, who is faculty co-lead of the consortium, Dr. Alison Finney, also faculty member at UBC, who has been a steadfast supporter from the very start of the consortium. And we also then have Professor Emerita, Dr. Judy Lynham, faculty member and expert in public health, last but not least, Ranjit Dari, who is also here today. So I acknowledge also the many nursing and health history scholars and students who have been part of it over the years for valuable contributions in very different ways, visits, scholarly activities, and also an important contribution always comes from the people from the UBC library on campus. We launched the consortium with the idea that nursing history scholarship is an essential component of nursing knowledge and research, and that the consortium would be a place to meaningfully support the scholarship and bring together students, faculty, and the wider community of the School of Nursing around opportunities to explore and examine nursing and healthcare's past. One community that calls for special acknowledgement in this effort is the BC History of Nursing Society, many members of which are also friends and alumni of the School of Nursing and known for their long-standing and many contributions to nursing history. And then secondly, probably the most key reason that we celebrate today and making this symposium special is that we are honoring the legacy gift of the late patron of the consortium, Helen Shore, whose photo you see here in the back. She left to the School of Nursing in the focus of the Helen Shore Nursing History Fund, a very special endowment that of up to $2 million to support nursing history activities in the school and in the school's community. I will tell you a little bit about Helen Shore, who sadly passed away in 2020 at the age of 95. As Associate Professor Emerita of the UBC School of Nursing, and also as a founding member of the BC History of Nursing Society, Helen Shore was a strong and committed supporter of nursing history, in which she had a strong interest throughout her career in public health and nursing education. Helen was proud of sharing common ancestry with Florence Nightingale and of being the daughter of pioneering health professionals in Alberta. She began her own career in nursing in 1946 with an RN diploma from the Vancouver General Hospital. And as her career continued, she emerged as an influential nurse in Vancouver, especially in public health nursing. She became faculty member at the UBC School of Nursing in 1965. And as a member of our faculty for 25 years, she actively was involved in curriculum development, both undergrad and graduate education. Helen was a strong advocate for nursing's voice in policy, raising awareness of nursing's important roles in addressing public health problems and inequity. Upon her retirement in 1990, Helen remained dedicated to the school. She helped establish an internal research award in public health nursing, and in 2013, she generously supported the launch of the Consortium for Nursing History Inquiry in the School of Nursing, in which she remained actively engaged as the consortium patron. And as said today, we remember and celebrate Helen Shore for the legacy she left to the school in the form of this Helen Shore Nursing History Endowment. It will support nursing history initiatives in the school in the form of nursing history research initiatives, fellowships, and knowledge translation activities, and also with a particular view to support the Consortium for Nursing History Inquiry and its goals. We deeply appreciate her enthusiastic interest in the school, her commitment to the profession, her ardent advocacy of public health nursing, and strong commitment to nursing history. Today's symposium on the history of public health and public health nursing in that way also is a tribute to Helen Shore. And that brings me to the third reason this symposium is special, and even more special on a snowy day in Vancouver. It is worth celebrating that we are again able to gather in this particular form that we do today, virtually and in person, after a long period of the COVID pandemic, which has so deeply impacted us all, as our society, our profession, and our relationships. It seems therefore timely to create space, physically, virtually, and mentally, to reflect on the meaning and consider its impact on communities, populations, and healthcare, and do so by looking back at the larger context of pandemic history. We will do so in the form of today's keynote presentation by Dr. Esyllt Jones. We are so fortunate you are here, and I will introduce you more fully in a minute, which will follow after these opening remarks. At the end of her lecture, there will be time for questions with the audience for a little while, and then we will have a half-hour break, and for us in the room for refreshments, and for people who join virtually to take a break from the computer. And then at the 11:45, we will continue with a panel discussion, which with Esyllt Jones and the three panel members, who I also will present. You saw at the slide background at the start already who they are, but I will introduce them more fully at the start of the panel discussion. So for people who join virtually, at the end of the opening lecture and following the commentaries of the panel, there is time for this questions. And so all of you who are joining online, please put your questions in the Q&A box that you see on the bottom of your screen. And then we will address them in the discussion period along with any questions you may have here in the audience in the room. So I'm now then very glad, before we start with the actual presentation by Dr. Esyllt Jones, to introduce you to Dr. Elizabeth Sewick, Professor and Director of the School of Nursing. And in many ways also, we are fortunate to have you public health background, Elizabeth, who in that capacity, as well as in her directorship, led us through the difficult period of the COVID pandemic in the school. So I'm very happy you're here and join us for part of the morning session. And you will have a chance to give some opening remarks. And so this is just back to the background. Okay, Elizabeth, the floor is yours.
Good morning, everyone, and thank you for the introduction, Girchi. Congratulations, Consortium, on a 10-year anniversary. This is a really important one. You have done amazing scholarship over these 10 years, and it's wonderful to see that the patron, Helen Shore, who has been an active emerita for sure, and has been someone I've really enjoyed spending time with over the years, has left this legacy as part of her commitment to nursing history scholarship. And in addition to the endowment providing funding for history scholarship and for fellowships and for symposiums like this, her generous donation has also provided funding for space. So as many of you know, our School of Nursing is going to finally have, after 100+ years, a purpose-built space, the Gateway Health Building, that we will be sharing with the School of Kinesiology and with Student Health. And within that space, Helen Shore has donated some funding for a specific classroom and meeting room of about the right size for symposia like this, but filled with the latest, greatest tech so that it can continue to be a hybrid experience. In addition, she's providing funding that helps with an archival office and storage space for many of the artifacts and the archives that the BC Nursing History Society and our History Consortium have accumulated over the years, because although increasingly historical scholarship does take advantage of scans and the internet and electronics, there's still a lot of materials and material property that is part of that historical experience. I'm particularly excited about today's symposium because, as a public health nurse, I'm like, yay, the topic. And especially as a public health nurse who has navigated the current pandemic, which is still not over, but is at least at a somewhat more manageable experience for the most of the population. But I'm mindful that, in fact, the very establishment of our School of Nursing as the first baccalaureate degree program in Canada, and indeed throughout the British Commonwealth countries, was established in 1919 as a result of the pandemic of the time, and with an emphasis on a certificate in public health nursing and a commitment to public health, leadership and administration, and education. And while that first baccalaureate degree has expanded to include Masters of Science in Nursing and PhD and Masters of Health Leadership and Policy and Masters of Nursing nurse practitioners, and while we are looking to the future with a Masters of Nursing and nurse anesthetists, we're still committed to those major areas of expertise: public health nursing, nursing education, and nursing leadership, which are more critical than ever 100 years later. So I welcome you to this, what will seem, I'm sure, will be a very stimulating and thought-provoking history symposium. And congratulations again on the 10th anniversary. Thank you.
Thank you so much, Dr. Sewick. And so now it's my honor, really, to introduce our keynote speaker, Dr. Esyllt Jones, who will present on the symposium's topic for today. Dr. Esyllt Jones is a professor in the history at the University of Manitoba. She is internationally known for her scholarship on the history of health, public health, and pandemic history. Dr. Jones is a passionate advocate for greater health equity. Her scholarship centers on health policy, working class history, 20th century activism and politics, and transnational social movements. She authored the award-winning book on influenza 1918, Death, Disease, and Struggle in Winnipeg. That was published in 2007, and most recently, she co-edited Medicare's Histories, Origins, Omissions, and Opportunities in Canada, and was just recently published this year. A collection of essays on the gaps and equities and opportunities in health reform and the role of communities driving this reform. Currently, Esyllt is president of the Canadian Society for the History of Medicine, and earlier this year, we saw your photograph in all newspapers. Esyllt, she has been named a Fellow of the Royal Society of Canada, and we are honored you're with us today to reflect on the history of pandemics in relation to public health and the inequities we have seen emerging in the COVID-19 context as well. We look forward to your lecture, Pandemic Caring, Public Health Nursing and Community in the History of Infectious Disease. Welcome, Esyllt.
Oh, thank you.
Thank you, Gerta, for that very generous introduction. It's really amazing to be out here on this. I'm looking outside at that absolutely amazing scene of all these leafy green and wonderful trees, which I associate with BC, covered in snow, which I associate with Winnipeg, where I have lived for many years. And I thank you so much for the invitation to come and speak to you today. I'm not a nursing historian per se, so the talk that I'll give today tries to bring connections to different parts of the work that I've done and ways in which I've reflected on pandemic histories. Over the work on the flu was my PhD dissertation. It's quite a long time ago now, and never expected really to be living through this particular history, despite having written quite a bit of work on it. So in these two global pandemics, influenza and COVID, more than a century apart, nursing has taken center stage. In the 1920 influenza pandemic, which was an era before Medicare, quite long before Medicare, and as a part of a struggle against a virus for which there was no vaccine or effective medical treatments, nurses were very visible, not just in the hospital or emergency hospital setting, but in the community itself, and in homes. That image of pandemic nursing is somewhat distinctive from the image that we have of nursing today. I'm just going to try to advance my slides here. There. Somewhat different from the image of nursing that we have in the COVID pandemic, which is largely images of the nursing workforce for their role in critical care interventions for very, very sick people, and the incredible emotional and physical toll that 21st century nursing takes on an undervalued workforce. So in many ways, the differences between these two images of women in the community and images of women in the ICU, for example, represents the transition of 20th century nursing and healthcare itself, a transition that has created a health system in which the balance, in my view, is off between tertiary care and technological fixes and the required social change to bring greater health equity and accessible community level healthcare supports. So I want to talk a little bit about these issues in my talk. Talk about pandemic influenza itself, talk about the interwar period, which I've also spent quite a bit of time working on in my work, especially for Radical Medicine, which was a book I published in 2019. Thinking about this era as a post-pandemic era of lost opportunities, and conclude by talking about national Medicare debates in the 1960s, which were in many ways a second chance to get the kind of balance in healthcare right. Again, mostly unsuccessful. And to just conclude with a few words on nursing opportunities and rethinking public health. That I'm a little bit going to be a little bit clunky with my slides, so I just want to apologize in advance for that. I'll leave this up for a second, and then I'll put up an image relating to the flu pandemic. So, tracing the longer term of the influenza pandemic on public health and health services is still really a very unfinished project, and relatively few historians have turned their eyes to that problem. In epidemic history, we tend to focus on the epidemic moment, what Charles Rosenberg calls the dramaturgy, the beginning, the middle, the end. There is, an end in this way of looking at the past, and doesn't often move past that. And that's particularly true for pandemic influenza history, because influenza comes and it creates a terrible crisis, and then it seems to leave. But I've always wanted to look beyond that in my own work. And the interwar years, by which I mean the years between the end of World War I and the end of World War II, so a little bit different maybe from other conceptualizations of the interwar period, but it generated a lot of shifts in thinking in healthcare, which can be related partly to the pandemic and partly to other aspects of crisis in society, especially the Great Depression in that period. And that period will eventually lead to what we now call Medicare. The new models that circulated at that time really tried to improve access to both preventive and curative care, which is why I want to talk about it today. This sort of notion of integrated care that didn't privilege one or the other at the other's expense. Nursing's inclusion in those models, which was very important, had the potential to create new recognition and roles for nursing in public health and at the community level. So to talk a little bit about the pandemic, by the 1918 flu pandemic, of course, nurses in Canada and the US had already had decades of experience nursing at the community level, where public health nursing and community nursing were not really considered distinct categories. According to my former colleague, nursing historian Marion McKay, Lillian Wald, a registered nurse and social reformer who founded the Henry Street Settlement in New York City in 1895, coined the term public health nurse in 1893 to describe the nurses who worked in poor and middle-class communities rather than in hospitals or in the homes of wealthy employers. So the original definition of public health nursing was itself slightly different, I think, than the definition that we might have today. It took some time for governments to take note of the work that nurses were doing to prevent illness and promote the health of vulnerable populations. And those included immigrants, the urban poor, infants and children, and families living in rural and northern areas of Canada. As early as the 1880s, small urban nursing programs had emerged in Toronto and Montreal, serving poor families and giving support such as clean, sterilized milk for infants and young children. The Victorian Order of Nurses, formed in 1897, contracted with charitable groups and sometimes local governments to alleviate the health consequences of lack of basic urban sanitary infrastructure, for example, labor exploitation, poor wages, some substandard housing. And their work focused in those early years, especially among mothers and babies. Privately funded and run organizations, some of them with religious affiliation, emerged in the first decades of the 20th century. Let's go. There we are. And the Margaret Scott Nursing Mission was one of these, founded in 1905, the Lethbridge Nursing Mission in 1909, and the St. Elizabeth Visiting Nurses Association about 1910. And certainly concern about high infant mortality rates provided one rationale for philanthropic and government support. In the city of Ottawa, for example, which had the highest infant mortality rate of all Canadian urban centers in 1916, more than 22 out of 100 of infants died in their first year of life, which is a truly, incredible number. Vying with places like London, England, for example, which had similar infant mortality rates in that era. This, along with the undiminished persistence of a number of infectious diseases that impacted children, like diphtheria or measles, led many public health leaders to focus on mothers, especially working class mothers. So school-based nursing initiatives also emerged at this time. Nurses were employed to inspect school children, especially in newcomer and working class areas, to detect communicable diseases like tuberculosis. In some cities, including Winnipeg, school boards also hired nurses to do home visits, and home visitation was a key component of this kind of community nursing. So education aimed to teach mothers what were considered modern health practices. And this was part of a larger movement about scientific practices and hygiene around parenting also, and housekeeping. And in effect, this was a process, among other things, for assimilating poor immigrant families into cultures of housekeeping, parenting, and hygiene that were not determined by these families themselves, but by social workers and public health nurses who came from a dominant Anglophone or Francophone cultural background. So in cities like Winnipeg, which was the most multi-ethnic city in Canada at that time, immigrant mothers who came from distinct health cultures with their own traditions and practices, and working class women who trusted the health advice of their female kin, for instance, often found themselves on the wrong side of this equation and facing just judgment rather than assistance. Over time, professionalized staff displaced the volunteer women who had founded many of these organizations, like in Quebec, the Coup de lait. In Montreal, Anglophone and Francophone milk depot clinics increased in number from 4 in 1903 to 28 in 1915. The city of Montreal then became directly involved in delivering these services in 1919, and then within a decade it operated 27 baby clinics. So there's this process that nursing historians have written about, of this movement from a voluntary or semi-voluntary nurse-led initiative to one that was increasingly governed over by public health planners, elite leaders, and mostly male experts. Some of them physicians, some of them people with training in public health itself. So as the public health system developed, then it evolves into a gendered form of health service, as obviously nursing as a whole does. Female public health nurses and social workers were seen as especially suited to working with mothers, in part because they were women, but also because nurses were characterized by their apparent unique feminine qualities of caring and nurturing. Nurses could also be paid significantly lower salaries than male health professionals, and thus constituted a cheap source of labor for public health work with women and children. And seen in this kind of equation as subservient, public health and visiting nurses were clearly instructed to steer clear of things like diagnosing illness, prescribing medicines, or treating illness, which was seen as the remit of physicians who were in this period overwhelmingly male. So public health nursing at the time of the influenza pandemic then was this mixed public-private enterprise and only minimally resourced by the state. And that helps to explain the hybrid nature of the pandemic nursing response. And Linda, I can't see you. Where are you? Linda has written about this. So I'm drawing on her work and the work of other nursing historians who write about the voluntary aspects of nursing during the World War I period. So in Winnipeg, this hybrid nature involves Margaret Scott, the VON, and municipal public health nurses. The Margaret Scott Mission was located in George Street, on George Street in the Point Douglas neighborhood, which was right near the immigration sheds and close to the CPR train station. It was originally operated by an all-female board of management, and it had a 10-member male advisory board. Very interesting bifurcation there in its early days. Its mandate was to provide nursing care to the poor of the central and northern parts of the city, and the organization received a lot of financial support in this period from prominent Winnipeg philanthropists. And many of the female members of the board were actually wives of these philanthropists. So there's a, this kind of the way in which the class relations here work were important. The mission over time also benefited from City of Winnipeg grants. So the city gave them some funding, as well as a close working relationship with both the city's health officer, Alexander Douglas, and also the Winnipeg General Hospital. And the nursing program there sent some of its senior nursing students to work at the mission. So there was, like in the hospital setting, there was this component of student labor, nursing student labor, that contributed a lot to the work of the mission. So it functioned within a classic feminine philanthropic paradigm, which emphasized the incapacity of the poor and the superiority of Anglo-Canadian values and culture. And like other private and public welfare agencies, the mission emphasized the dangers of what we would now call dependency. And, in that era was referred to as pauperization. That is, wanting to steer clear of the notion that people should receive support that would discourage them from independence, either financial or social independence, and in particular, dependence on the state was to be discouraged. So what does this mean in healthcare? Well, not just at the nursing mission, but also at places like the Winnipeg General Hospital, where people could go and be treated if they couldn't pay. But the trade-off there was a detailed scrutiny on your financial situation. So also at the mission, people were carefully screened to be able to receive nursing care. The perceived successes of the Margaret Scott Mission had inspired Winnipeg's chief medical officer to include a program of visiting nurses as part of the new Bureau of Child Hygiene, which was created in 1913. And it opened a house in the North End where mothers could take their babies. It provided free medication, clothing, and food in some cases. By the end of the First World War, the Bureau employed 9 nurses and operated a baby clinic and a milk depot. And this is part of that process of professionalization that's occurring in this period. The Bureau had taken over the operation of the milk depot from the Ladies Service League, who had initiated the project in 1908 to provide free formula and medical care to poor mothers. By 1919, there were 2 attending physicians who worked with the Bureau of Child Hygiene and staff conducted about 4,000 examinations every year. And the clinic was also used as a training facility for nurses and medical students. But when influenza hits Winnipeg, It's the small handful of nurses at the Margaret Scott Nursing Mission, some nursing students, and these 9 municipal child welfare and tuberculosis nurses who were responsible for caring for poor victims of influenza initially, right? Everyone is overwhelmed with requests for help. So the Margaret Scott's Nursing Mission's records are in the archives. Their ledger books are in the archives, and they are accessible, really quite wonderful sources, show that it provided care during the epidemic to a lot of poor immigrants who may not have otherwise received any form of health care during the influenza pandemic. Hundreds of immigrant families were treated by the nurses. In many cases, these were very difficult and upsetting circumstances. Nurses would find entire families infected with influenza, parents and children, with no one in the household well enough to provide even basic nourishment and hygiene, which is one of the reasons that influenza had such a high mortality rate and why nursing care could make a difference. Because when everyone is infected, there's no one to cook, there's no one to get fuel for the home. This really contributed to high death rates. During the pandemic, there were 1,380 home visits made to patients, and nearly 400 more made in early 1919 in the kind of smaller wave. The organization had to respond to this crisis without its director of nursing, who became ill herself with influenza and was hospitalized twice with complications. The work of the mission's nurses was assisted by volunteers and also by many physicians who volunteered their time. As many as 30 to 40 doctors helped the mission every month at the peak of the epidemic. And some of the load was also shared by the Victorian Order of Nurses, which provided nursing support for a company called the Metropolitan Life Insurance Company. And I'm sure there are a number of you here who know more about the history of the VON than I do. Pandemic caring was performed both by formally trained nurses and by hundreds of volunteers who helped families with food, clean linens, and basic supportive care. Just going to see what my next slide is here. No. I'll just go back to this one. There. So this voluntary piece was really important. Doing basic supportive care, providing food, providing clean linens to people who were affected in their homes. And the exact numbers here are impossible to know. We don't know exactly how many women volunteered. We don't know at all how many people they saw because there really were no formal records of these efforts. Some of the voluntary efforts were organized along ethnic lines by immigrant communities, and the records of those activities are almost impossible to trace. So the Anglo-Canadian Volunteer Project, which I wrote about in Influenza 1918, alone included 650 women. Elizabeth Russell, who was the newly appointed head of the Provincial Public Health Nursing Department, and 2 other nurses from the Winnipeg School of Nursing staff trained volunteers at the Manitoba Medical College to be able to go out into people's homes and provide support. So these volunteer efforts built on the availability of trained nurses who weren't employed or who had left nursing after marriage, which was the norm at the time. And the wartime mobilization, like the Winnipeg Women's Volunteer Reserve. And, there were about 50 of these women who already had received volunteer reserve training who were involved in caring for flu cases. So the response to, and this is one of the things that I've thought about a lot during COVID, the response to the pandemic was in any number of ways, and nursing is only one of them, really importantly rooted in voluntary effort. During the COVID pandemic, there was a lot of voluntary effort, but not in a kind of high level publicly. The Winnipeg Free Press would cover these voluntary efforts every day, right? So it was seen as central. Now this makes sense. The welfare state at the time is tiny. There's no capacity there. There's no Medicare, there's no income, very few income support programs and so on. But the hybrid nature of it, I think, is one way that distinguishes the flu pandemic from what we've been through with COVID-19 to some extent. So the flu pandemic, how did it affect healthcare and public health? Well, it certainly highlighted a lot of problems with Canadian health care and with the health of the Canadian population. One of these, of course, was the impact of social inequality, which was reflected in a social gradient in death rates. The most seriously impacted by that social differential were Indigenous people who had death rates sometimes 10 times higher than non-Indigenous folks. And that's measured using on-reserved Indian records. So it's not a perfect figure, but it's reasonably reliable for the data that it includes. So the close relationship between poverty and poor housing, social marginalization, colonialism, and discrimination, of course, was nothing new during the pandemic. But as during COVID, the fact that flu raged through the entire community, affecting people from all different backgrounds, albeit differentially, creates a sense of a shared vulnerability that then casts health inequities in a different light socially. The lack of equitable access to medicine and nursing care and the inadequacy of resources to cope with the major disease outbreak is certainly highlighted by pandemics. In 1918-19, another concern, as today, was public trust, which was shattered during the pandemic. Trust in the capacity of public health to respond, the capacity of the state itself. I've written elsewhere about the extensive soul searching in public health circles that followed the pandemic. Confidence in what was then called the new public health, which was a combination of sort of bacteriology, surveillance, and early epidemiology, was fractured. Public health officials spoke openly about needing a new approach in the future. Canada created its first National Department of Public Health in the pandemic's wake in 1919. Provinces followed suit unevenly and sporadically over the interwar years. So at the time of the pandemic, the only province that had an independent health department was New Brunswick, which had founded their Department of Health in 1918, in the middle of the pandemic. So New Brunswick is interesting because it was influenced in the way it set up public health in that new department. It was influenced by innovative models for public health that were then emerging in the United States, especially to do with rural health. So New Brunswick created a new district system that was staffed by multidisciplinary teams of care providers, district medical health officers, sanitary inspectors, and public health nurses, ran free government finance clinics in order to control tuberculosis and venereal diseases, which were in that period the ones that received the most attention. They offered educational classes on nutrition and infant care, inspected the health of school children, and administered, in New Brunswick, mandatory smallpox vaccinations to kids. I don't want to go into that issue, but there's no sort of unified picture on whether vaccination is mandatory in that period in Canada. It varies a lot. So during the interwar years, rural areas became sites of public health innovation, which is interesting when we think about where we're at now. Although the Depression did lead to budget cuts in a number of provinces that threatened some of these innovative programs. The Rockefeller Foundation was an active participant in and funder of public health developments outside of the US borders. If any of you know anything about what the Rockefellers were up to in that period, they were everywhere, really everywhere. In Canada, they supported the creation of rural health units in several provinces, and the only ones of these that have been extensively written about are the ones in the Maritimes. They also funded the first Canadian School of Hygiene at the University of Toronto in 1927. And the Rockefeller Foundation funded public health training fellowships for Canadians who were almost all men during this period, which has an interesting connection to my Saskatchewan work. You could ask me about it after if you want. One of the people that they sent for training was a man named Dr. Alphonse Lessard, who was director of the Quebec Provincial Bureau of Health. And he was influenced by his study of county health units in the rural sections of North Carolina and Ohio, and applied this model in Quebec, beginning with a demonstration unit in 1926, and then over the next 5 years, 23 additional county health units were established in Quebec, with 160 staff serving over 750,000 rural people. Nurses formed the largest staffing category in projects like this one. These unités sanitaires delivered care closer to where people lived, largely through the efforts of public health nurses who worked outside of major urban centers. Other provinces were well aware of developments in Quebec, and they were certainly extensively profiled in the literature of the period. In Nova Scotia, a new Department of Health was created in 1931. So even into the 30s, Manitoba's was 33. There's a considerable lag, right, in developing provincial departments. Rockefeller Foundation supported report on public health was issued in 1935, and Nova Scotia created 5 new public health units modeled on that report to provide health education, maternal health supports, inoculation, treatment of children for childhood respiratory and digestive diseases, all delivered by public health nurses. This system, as historian Sasha Mullally, who's written about this, didn't replace the patchwork that existed at the time of rural physicians and boards who provided some basic health services and public health preventive services. It kind of ran, I think of it as running parallel to that system. That's my way of thinking about it, not Sasha's. So I think of it as these rural health units were not well integrated into what was going on elsewhere in the healthcare system, such as it was in the 30s. In the mid-30s, most rural health officers were local physicians who were paid a modest honorarium to undertake basic public health tasks like infectious disease notification. And the new public health nurses weren't meant to supplant that physician role, but to augment it and support it without challenging it, right? So there's a few historians who have written about this very interesting period. As Megan Davies argues, these nurses walked a fine line between science and humanism, and she's writing there of British Columbia. Proactive nurses pushed against the boundary between preventing and curing, expanding the role of public health in rural areas. They divided their time between clinics and schools, home visitation, and bedside care in like little sort of fledgling clinics and hospitals, in addition to spending a lot of time documenting, right? In some cases, midwifery became part of public health nursing practice. And given the shortage of physicians in rural areas and the large distances that needed to be traveled, a problem which was by no means unique, of course, to the maritime region. It characterizes big parts of Canada. Public health nurses were fulfilling a need and responding to local demand. And those relationships in the here and now didn't fit nicely into tidy categories about what was public health nursing work and what wasn't. So by being present in the home when children were born, public health nurses built a relationship with clients, which would, come to include a lot of different things, right? Monitoring infant health, administering vaccinations, and being called on in cases of illness. But this approach, which was, broad, was out of step eventually with the goal of public health policymakers. So Nova Scotia assessed this program in the 1950 Survey of Health Services and Facilities. It drew a firm line between public health nursing and private medical practice, or really between preventive care and physician-delivered primary care. And these are distinctions that are really important for what happens to these models. So the Nova Scotia experience resonates with conclusions that Megan Davies drew about the reforms in BC in the 1930s. And she writes, community healthcare initiatives with strong grassroots support from local residents were replaced by a system that emphasized central surveillance and administration, scientific methodology, and public health professionalism. And Davies argues that this created what she calls a depersonalized model for public health. And here I see it as a lost opportunity to sustain effective prevention programs that benefited from community trust. And I'm exploring these ideas partly to follow this notion of close to home and relationships, and how trust either exists or doesn't exist in public health. For public health nurses, this kind of, more hierarchical, rigid, professionalized model meant fewer chances to serve the actual needs of the communities where they worked. They were kind of hemmed in by a system that was led at the top by elite male public health administrators. So Davies did some oral history interviews in her project and reflected years later that public health nurses, quote, had secured professional recognition for their efforts, but had failed to convey to the people of the province the value of what they had created, which I see as a comment that illustrates the complicated politics of public health in this period, which is pre-Medicare. So, I think what she's getting at with convincing the public of the value of what the public health system did was essentially a political argument. In order to see significant lasting change in the healthcare system, the public needed to understand what that system could do for it and to advocate for it. But in the course of this depersonalized move in the interwar years, that political opportunity is also kind of pulled away from the system. Having said all that, the Depression years were a critical time in the history of Canadian healthcare, and I've written quite a bit about that period in Saskatchewan. Political support was building all over the place, Canada, the US, Britain, elsewhere, for the full socialization of healthcare. Canada was at that point still 3 decades away from the introduction of insured medical care, but by the late 1930s, the need for some form of medical and hospital insurance seemed a foregone conclusion, right? If we just forget for a minute that it took another 3 decades, at that moment, it seemed really about to happen. So consequentially for public health, calls for healthcare and access to treatment came to dominate public conversation about health reform rather than preventive care. Haggerty, the future chair of the Federal Advisory Committee on Health Insurance, wrote, "The trend of public health is toward health insurance," which is always a sentence that I puzzle over. The trend of public health is toward health insurance. So for the first time since the late 19th century, the role isn't on the preventive role of public health and infectious disease, but rather on how to give ordinary people access to care when they become ill. And that's where the political energy comes from. So advocates for socialized medicine, the most radical of proponents for state involvement in healthcare provision, developed a unique model for health reform to provide access to quality healthcare, but along a continuum from prevention to cure. Activists in Saskatchewan drew on ideas from the Soviet Union, Britain, New Zealand, and the US. In Canada and the US, the health center model was especially innovative in its plans for how to deal with rural health equality, especially, and accessibility to quality services. The model had several principles that I've written about in my work that distinguished it from health insurance. So socialized medicine and health insurance are not the same political program. One of the things that distinguishes it was the integration, the intention to integrate public health and treatment, or prevention and cure. And seen as one of the successful aspects of Soviet medicine and the way Soviet medicine was organized. Integrated care was to be delivered at all-in health centers, staffed by multidisciplinary teams, and as conveniently located close to families as possible. So in Canada, the moment of opportunity to develop healthcare along these lines comes after the election of Tommy Douglas in Saskatchewan in 1944. And, Tommy Douglas is known as the father of Medicare, but at the time he was elected, the model that his supporters advocated was somewhat different from what we have now.
The grassroots and political activism that carried him to power on a health platform had a very specific health reform agenda, which was also reflected in the work of its health commission. The photo in the slide here. Right after the election, Douglas immediately appointed immediately appointed Henry Sigrist, who's this guy right here, to lead his health commission, which was it wasn't like a royal commission. It was all over in 6 weeks, and it was very, very focused. Sigrist was born in Switzerland. He was a well-known public advocate of socialized medicine. He wrote a book called Socialized Medicine in the Soviet Union. He was on the cover of Time magazine in 1942, which gives you an idea of what the flavor of things was in 1942 versus, say, 1950, by which time he was driven out of the US during the Cold War. He was then a professor at Johns Hopkins Medical School, and he agreed to come to Saskatchewan and spend 6 weeks touring around with this group of people. I believe this person right here is Anne Morton Heffel, who was a public health nurse. The woman standing in front of her is Mindel Cherniak-Sheps, who was a physician from Winnipeg. I've written quite a bit about Mindel. Very unusual role that she had as a woman on the commission. The Sigrist report recommended a regionally organized set of health services based at the bottom in small rural health centers and hospitals serviced by larger district and ultimately large urban hospitals where specialized care would be provided. And the regional flavor to the model is really very common in that period, coming from a number of different political perspectives. Like other models of its time, it emphasized the need to maximize the contributions of a range of healthcare providers, including nurses, and de-emphasized the role of the private practice physician. So from 1946 on, this is 44, from 1946 on, the person most responsible for implementing Douglas's health agenda was an American, Fred Mott. Guy in the middle there. This is on the left is Milton Romer. Some of you who do health history may have heard of Romer because he is quite a well-known figure and did some historical work also himself. And this is Len Rosenfeld. And Mott and Rosenfeld together built the hospitalization program that was introduced in 1946 in Saskatchewan, the first universal health coverage program in North America. And Mott is an interesting figure. What happens with he's hired to make that hospitalization thing work. And, the hospitalization program was the way in which Douglas won his political war, right? He gave people what they wanted. They wanted access to medical care. But it does not so good things to the model that had been in the Sigrist report. So Mott's interesting. He was a graduate of the McGill Medical School and for several years the head of health services for the Farm Security Administration, a New Deal program in the US that helped to create health cooperatives across the US using innovative methods of health delivery to care for vulnerable migrant farm workers in the depths of the Depression. And in a speech to the Wisconsin Welfare Council in 1942, Mott talks about the multidisciplinary model of care. Healthcare teams should include public health workers, nurses, the medical social worker, a health educator, and a physician. I mean, these roles are interesting. They're kind of, they don't sort of fit together in the way that we might think they should. Nurses played a key role in the work of the Farm Security Administration health programs and continued to do so during the Second World War when it was called the War Food Administration Program. In 1946, in its report of activities, nursing occupied nearly a quarter of the program's spending. To many farm workers, the report said the clinic or field nurse was their only contact with the farm labor health program. In peak seasons, more than 300 nurses were employed in all associations. That's the rural health associations that they were like cooperatives that they helped form. Nurses alone, acting under standing order, handled 265,000 cases, 2.5 times as many cases as those seen by physicians, which is a pretty broad expansion of scope in that context during the 30s and early 40s. So nurses worked all over the place in this program, from migratory worker camps through local clinics and hospitals, small hospitals that were built by the FSA. They had a handbook that I've seen illustrates all kinds of work that nurses were doing, home visits to patients' residence or migratory farm labor camps, treatment and prevention of contagious diseases, including diphtheria, scarlet fever, measles, smallpox, malaria, clinics, and field nursing visits to patients. Nurses provided monitoring and care for venereal disease and referrals to physician care where necessary. Testing and immunizations could be done in the program by either a physician or a nurse. Specific immunizations that the report mentions include typhoid, smallpox, diphtheria, and tetanus. And nurses were responsible for tuberculosis control and treatment, referral to sanitaria or other treatment centers. Maternal and child health was a creative area of work, as they put it, with ideas of having health conferences, which were like meetings with a group of expectant mothers and mothers of young children brought together to talk about maternal and child health problems. Nurses also delivered maternal and child health care in the field, as well as visiting nursery schools to inspect children. So the underlying philosophy of these health programs really challenged the power of organized medicine in the US. It had a multidisciplinary approach and what was called a broad, by the historian of this program, Michael Gray. If you're interested, you could read his book, New Deal Medicine. He refers to its broad public health orientation. So these programs remunerated the private rural physician, but they also employed a range of other staff. And the delivery of migrant health programs, which was meant to be a template, this is where it gets sticky, right, for broader health reforms. This model was supposed to be a template for what could be achieved at the national level at a time when these reforms were being debated. It really achieved a relatively high level of multidisciplinarity, at least on paper. I mean, I don't really know how it worked on the ground, giving extensive scope to nurses to deliver primary care, incorporating other technical and social welfare professionals. Administrators were careful, though, to try to form positive, pragmatic relationships with rural physicians, and did attempt, although ultimately unsuccessfully, to bring organized medicine on side with the model, even though it economically supported struggling rural doctors, right? So certain doctors benefited from the program, but others not so much. The multidisciplinary team model of healthcare organization, which was also often twinned with arguments for salaried physician payment, was, it was radical, and it was opposed by organized medicine, which was a very, very powerful lobby in the US in this period. That opposition would be echoed in Saskatchewan. So one of the reasons that you see the shift between 44 and the end of 1946 and the focus on new hospital insurance services is that organized medicine really opposed the Sigrist report model. And personally said kind of horrible things about Mindel. Some of this is reflected in David Naylor's book on Medicare. So, they didn't like her, right? She was a socialist, she was Jewish, she was a woman. I mean, the list went on, right? So let's talk about what happens in the 60s. Because of course, Saskatchewan goes it alone for a long time, and other provinces are making changes as well, but nothing coherent across the country. And the national Medicare debates, which began in the 60s, were kind of a second chance at a moment when this sort of model was still not completely, out of the question. In the context of wartime debates, when Canada did appear poised to introduce a national health insurance program, the Canadian Public Health Association called for an expansion to public health to include health insurance and healthcare provided by physicians, nurses, dentists, and full-time local health departments. Its public health charter, which was published in 1942, and its 1943 brief to the House of Commons Special Committee on Social Security, supported a national health insurance plan while continuing to press for grants and aid to provinces for existing public health programs. It also advocated the establishment of full-time health units with health officers, so something like that, sort of 1930s model. And these proposals attempted to sort of marry longstanding demands for better preventive infrastructure with the new societal focus on medical care. Well, these post-war plans for Medicare in Canada, like they did in the US, vanished into thin air, as my colleague Heather McDougall has argued. It wasn't until the Royal Commission on Health Services, the Hall Commission, in 1965 that the federal government makes its move on Medicare. And when it did, community-based preventive and supportive care was sort of thrust aside in the favor of a fee-for-service medical insurance system, the one we have now, and extensive support for hospitals and other really acute care infrastructure. At the outset of the Royal Commission, there was promising attention to public health, and here public health must be read broadly. The Commission included a detailed report on public health's role called Organized Community Health Services, authored by John Hastings and William Mosley. And the volume recommended comprehensive public health services across the country with strong links to social services as well as a major role for public health within a coordinated health services structure of regional planning and executive boards. Public health advocates at this time supported the recommendations for health coverage, but were disappointed ultimately in the limited reference to public health in the Hall report. Evidence from interviews and private correspondence suggests that the minimal reference in Hastings and Mosley's recommendations to the Hall Commission report was a result of attempts to placate organized medicine and the hospital sector. So here we have, I just pulled a little bit of this out, to sort of indicate what the Organized Community Health Services report saw for nursing, right, and saw for health delivery, and the way in which it tries to integrate prevention and cure to some extent. So there's personal health care should be, carried out by physicians, blah, 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 especially the public health nurses. Greater attention should be paid to the use of auxiliary nursing personnel, so supportive staff for nurses, and also to sort of bolster the nursing workforce. So the Hall Commission report ultimately becomes, kind of another moment of disappointment for a model that was meant to be more integrative in nature. So politically that's going on. But the other thing that's happening here that really sets a different context for public health is the change in perceived natures of disease in the first place. So infectious disease control as a part of public health was impacted by the perceived nature of disease in wealthy societies, right, over the course of the 20th century. This narrative doesn't apply to most of the world, it just applies to certain countries. So overall, infectious disease mortality rates are declining significantly through the 20th century, and a greater share of deaths are caused by non-infectious conditions. At the same time, lifespan is extending. People are living longer. So there are fewer deaths, and more of those deaths that happen are happening from non-infectious conditions. So the percentage of deaths in Canada due to tuberculosis fell from 7.3, that's an incredible number, 7.3% of Canadians in 1931 died of tuberculosis, to 0.1% in 1981. Some of this is just the history of tuberculosis is an interesting one. It's called the social disease, but obviously antibiotics play a big role too, right, in that decline. Infectious and parasitic diseases declined from 5% to 0.4% of deaths in that same period. At the same time, cancer and cardiovascular diseases killed proportionately more Canadians in an overall context of increased longevity. In public health, as George Weitz, who teaches at McGill History of Medicine, has argued, higher emphasis on chronic disease incentivize the adoption of risk factors in population-based epidemiology and as the basis of public health. And the move toward the population health risk factor approach to public health de-emphasizes social conditions and social factors shaping health and emphasizes the individual behavior of people who are at risk. So the disease transition, the mortality transition, sets an important context here for what are otherwise political debates that have been going on for decades. So as this kind of model continues to sort of survive, a more integrative, multidisciplinary model of care, it's coming up not just say with the opposition, against the opposition of organized medicine, but also coming up against very significant shifts in how medicine is delivered and the nature of disease itself. So, you know, it's the golden age, right? Maybe the second golden age, because there was an earlier one in the 19th century, but, you know, vaccines to prevent childhood diseases. The polio vaccine had a huge, you know, impact on the shift toward a certain kind of biomedical approach to infectious disease. Measles, mumps, so polio is 55, measles 63, mumps 64, rubella 68, and then the MMR in 1971. Prevention came synonymous with mass vaccination delivered through provincial programs and campaigns. And this had ambiguous consequences for public health in that it highlighted pharmaceutical and technological fixes while de-emphasizing public health's traditional expertise in non-pharmaceutical and non-medical forms of prevention and potentially cure. So the growing trend to replace the traditional public health model of wellness, of healthiness and multidisciplinary approach with a preoccupation that reduced public health to the medical model of the treatment of disease. So there's a lot going on in a very critical period, I think, that I now see as this kind of interregnum of some sort. When, you know, globally, that's also the period when you see a lot of conversation about the eradication of infectious disease. Smallpox, the smallpox campaign occurs in that same period, but smallpox is the only one, you know. None of the other infectious diseases that still kill, you know, millions of people a year were, you know, defeated. But at the time, it was all about that, right? It was all about this amazing promise of being able to eradicate infectious disease, which, you know, by the emergence of HIV/AIDS looks just like hubris, right? And now it really looks like hubris, I think, is what it comes down to. I'm almost finished. So after 1918, I want to talk about forgetting for a minute, because a lot of what I'm talking about here, these different ideas for thinking about public health, community health, nursing, healthcare delivery are largely forgotten, even in the history of Medicare, which we think of in a very different way than people at the time thought of it. So there's this way in which forgetting is just ongoing, right? After 1918, the flu pandemic was officially more or less forgotten, you know, along with the role that nurses had played and the way in which the public referred to them as heroes, you know. In the years that followed, the only memorial built to the flu pandemic in Canada, any kind of memorial of any kind, was a statue in honor of this nurse, Ethel Gertrude Dickinson, who died caring for flu victims in St. John's, Newfoundland. Even still, in most histories of public health in Canada, the flu pandemic plays a fleeting role. Its impact apparently negligible. In histories of global health, which otherwise focuses extensively basically on infectious disease history, because global health and infectious disease are inseparable, the flu pandemic is almost absent. And it's funny how I've studied these things for years, and it was only this year that penny dropped for me. I don't know why. Like, how could it be that it took me so long to make this obvious observation? Partly it's through teaching, because this year I'm teaching a course in global health, and I'm using Randall Packard's book, The History of Global Health, which is a wonderful book in many ways and mentions the flu pandemic twice, in maybe in total, like maybe less than 100 words. And it's kind of fascinating to see how the way in which the flu pandemic weaves through people's responses in the early 20th century, especially the first half, is absent. Remembering the contributions of pandemic nurses, remembering the model for healthcare that emerged in the post-pandemic era, it takes good research, and it takes some conscious decision-making on, what you're going to focus on, obviously. Other aspects of the flu pandemic's history, for example, its persistence in private and familial remembrance, something I've written a lot about, and has been obscured not least because of the disinterest of historians themselves. So long-term changes in the post-flu world are really generally not well studied, and that definitely includes connecting the dots on some of the things that I was trying to connect today. Hopefully it makes sense. With regard to its impact on public health nursing, there's still a lot that we need to learn, and could learn if we looked more closely at it. Influenza isn't the only pandemic disease whose legacy is visible only in hindsight and took decades to unfold. And I was talking about this the other day with my colleague James Hanley, who's a 19th century British historian of public health. So even with a recurrent and highly feared disease like cholera, which, people are terrified, it comes and then it comes again, and it's a grisly disease, hits Europe, Asia, North America in repeated outbreaks from the 1830s to the early 20th century. Well, we think of cholera as, what do we think of when we think of cholera? We think of Jon Snow, we think of the insight that clean water saves lives, and so on. Well, it had little immediate impact on public health or sanitation in Britain or Canada or elsewhere. So we now think of cholera as being a catalyst for improved public health understanding, for example, of waterborne disease transmission and the need for clean water and sewerage. But Jon Snow's Broad Street discovery of cholera's connection to contaminated water took decades to be accepted, even by medicine itself and public health. Meaningful investment in sanitary infrastructure took even longer. And so if I think of Winnipeg, for example, the Shoal Lake Aqueduct, built on Indigenous land, stealing Indigenous water, wasn't built until 1919, wasn't finished until 1919. And people were still having to pay individually to hook their homes up to sewer lines, right? And this pushed people out of, working class people out of neighborhoods because they couldn't pay. So it's really important to take the long view when we think about how to understand the world that pandemics make, not on their own, but alongside other things, and to view them both as crises and as opportunities. So historical resonances between the COVID pandemic and influenza shouldn't be reduced to comparison alone. It's more than just comparing it, although comparing, oops. Okay, I'm just going to have to go through the whole thing again because I really want to talk about that report just for 2 minutes. There we go. Resonances between the two pandemics are about more than comparing, this factor, that factor, the other factor, but the two were also very different in so many ways, right? Including, the context of the long-term changes in public health and medicine that I've traced a little bit. But COVID has highlighted, as did the flu pandemic, inadequacies in preventive care, gaps in public trust, and the need to rethink the meaning of public health and its relationship to healthcare. And as in the interwar years, when inclusion of nursing as key players in a reform system entered the conversation, I think there are opportunities now for nursing to build on a century and a half of experience in public health and community nursing care, and to revisit earlier capacious understandings of public health nursing in the 20th century, to explore its validity in community settings, in homes where nursing has traditionally and historically straddled the boundary between prevention and treatment. This is Teresa Tam's report from this last year. And one of the interesting things about it is its emphasis on community. I don't know whether any of you here are familiar with this report. Its emphasis on the need to build relationship at community and to, involve communities in decision-making and creating better preventive services. Nurses are certainly mentioned in this report, but I would say that, that there's a gap here, which is, talk about it as an opportunity between a rough sense of what's wrong with the system, which isn't really so different from how the rough sense people had in the early 20th century, and how one might get to something better. And maybe there is an opportunity here to be aware of what nursing has to offer, how and why nursing input and authority and capacity are important, but also how and why they probably will be or might be resisted, so that we can anticipate barriers to change, which faced so many advocates over the years for a more socially just health system. Thank you.
Thank you, Esyllt. We will spend a few minutes for some questions. Is there a question from the audience? Right in the room, and then we go to, if there's one on in the Q&A box from the virtual group. There is one?
Not a question, but I just want to say, if you do have a question, if you wouldn't mind just stepping up to the mic so the online audience can hear it.
Okay,
well, in front of the audience there, on the right side there.
Okay, and that one is also working over there, so that can stay there. Okay, well, we have a question, some time for questions. Thank you, Esyllt, for leading us through the century-long, in many ways, evolution of public health and the role of nursing in it. To open discussion, one thought that came to my mind, in many ways, because of the system has so profoundly changed, in particular in the second half of the 20th century, in terms of a professional system of healthcare, multidisciplinary state support through Medicare, and then, like you alluded to, the particular transformation in cultural belief as to what healthcare should look like. And on the other hand, you also argue towards the end, maybe there is a way to go back to older models, or maybe revitalize them. And so my question is it really possible in many ways to revitalize older models in the face of this profoundly changed structure of healthcare?
Well, I think the models, the type of model that I look at in my work can be traced through the 20th century, including something I didn't talk about in my work, which was this sort of new community health center model that emerged in the 70s and 80s, which I'm studying now, which is, really a lot of fun. So it persists, largely from the bottom up. And I think one of the challenges that we face at this moment is that for people who may engage in health politics, the thing that really frightens people is the loss of insured services, the loss of Medicare. And this, that fear has been ongoing for decades in any case. But now we have particular, iterations of shifts toward more market-based healthcare. And I think, the need to continue to speak about alternatives, even as you're doing the work to safeguard the things that you value, is so important. And it will come, speaking as a historian, this will come from, maybe unexpected places, and maybe mostly from the bottom, not from the top. So I really think I really hope that as all this anxiety about Medicare becomes real to us now in post-pandemic, that people continue to believe or dream in some other alternative system that they would have input into and decide, right? So the interesting thing about the 70s and 80s is there are key differences with the earlier health center kind of model, and a lot of them have to do with the key social movements of that era: feminism, anti-racism, workers' health movements. So that the movement, that health center model, if we look for a common thread, gets reimagined in a new way by people who are part of broad social movements, and then of course, especially beginning with HIV/AIDS, gay rights, and queer healthcare movements. So interesting to see how it just keeps, I see it as irrepressible, really. It's just out there somewhere, just waiting,
Thank you. I'm wondering, is there a question in the Q&A box? Not yet. Okay, then we can turn to the audience in the room. Yeah, please. Jason, yeah.
I'm hesitant to ask because I think I'm the only male person in the room. I know that there's a long history of jumping the queue, but sorry.
Yes, please.
So my question is about financial risk. I always had the impression that part of the hospitalization insurance issue in 40s in a place like Saskatchewan was that John Farmer worries that he's going to be ill and have to go to the hospital and lose the farm. And not surprisingly, he's interested in the key part is important to it. He's interested in hospitalization insurance because it removes that risk. He may be less interested in actual diseases or public health concerns. You didn't sort of, I mean, perhaps you did, but I don't think you touched on that aspect of the change in the models that people have raised.
Yeah.
So there's a COVID parallel there too, right? Because people are quite fearful of losing employment or businesses because of these sorts of pandemics. So
Yeah, that's a really good point. And people did want and need acute care. And the uptick or the take up in when Saskatchewan first introduced its hospitalization coverage was massive. And I think a lot of it had to do with the fact that because physician services weren't insured, people went to the hospital to be treated. And yes, for illnesses that were, threatening their families and threatening their livelihoods. In that period, I may have presented it as a kind of either or as a sort of, I wish, I guess, that it hadn't been a trade-off, either one or the other. But the public need, not just demand, the public need for that was very important. In that model in the 30s and 40s, like someone like Fred Mott, for instance, in the work that he did on rural health in America, said that these are basically, two sides of the same coin. Someone who is ill cannot be productive. And someone, medical care or access to healthcare is as important to the person's life for example, avoiding poverty, as the other way around. So it's a different way of viewing a kind of, so when we speak about social determinants, we don't necessarily speak about access at the same time. But at that time, they really were speaking about both things, about access, but also about the need to prevent poverty, right? Which was driving these, movements, especially in the 1930s, that they were, the level of people's poverty was ruining their health. But so too was the lack of access to healthcare, which drove them into poverty. Yeah. Thanks. It's a great question.
Yeah, thank you. Well, I do think that we have some fresh coffee ready, and that I would like to thank you, Esyllt, because I know that after our panel discussion, and you will also be part of the commentaries on the panel presentations, there will be more time for questions as well, and that we now first have a chance to have a short break, and then we will continue. So thank you very much for your presentation. Okay, let's get back into the room here and get back to our virtual audience as well. Thank you all for your continued participation in this symposium, and for all of us to learn to deal with a hybrid audience of people who I can physically see and people who I assume are there. So we are glad you are all joining virtually as well. And it's now my great pleasure to introduce a panel of commentators who actually have had a chance to briefly meet with Dr. Esyllt Jones, and were willing to think through a particular aspect to either relate or comment on the particular presentation or on the larger relevance of public health and its history. And so to help us put in context, what we really want to reflect on is the meaning of pandemic history over time, and how we help that understand the context in terms of making sense also what we have just experienced and still experiencing in the current pandemic. So I'm glad to just in sequence briefly introduce our 4 panel members. And the first panel member is Dr. Sonja Griepma. She is an adjunct professor at the UBC School of Nursing. She is a public health nurse by background, and her scholarly work centers on nursing and missionary history. Her latest book, Nursing Shift in Sichuan, actually what is displayed in the UBC Press display here also, has just been recently published in 2021, and focuses on the Canadian missions and wartime in China from 1937 to 1951. The next panel presenter, who thereafter will present, is Dr. Helen Vandenberg. She is associate professor at the College of Nursing at the University of Saskatchewan, and she also is a public health nurse by background. And her scholarly work centers on nursing and hospital history. She recently published in BC Studies and the Canadian Journal of Health History on the wide range of community hospitals in BC and the history of hospital standardization. Then, physically in the room is Dr. Alison Finney, who is co-presenting with Dr. Mariko Sakamoto. Alison Finney is professor at the UBC School of Nursing. Her nursing background and scholarly work center on the health of older people in Canadian society. She publishes on the promotion of the well-being and meaningful engagement of older populations, especially individuals with dementia, and how to improve their physical and social environments. And her colleague Mariko Sacramento, who cannot be here today because he is actually presenting somewhere else, but they have prepared their presentation together. She is a nurse researcher interested also in how to, the health, well-being and quality of life, how that can be enhanced for older people. She is currently a postdoctoral fellow funded by the Alzheimer's Society of Canada and at the School of Social Work at UBC here in Vancouver. So with further ado, I welcome Sonia for her first 10-minute presentation. We will do all the presentations in sequence and then have about half an hour for discussion, so we can attend to all questions that were also in the Q&A box just previously, and attend to questions from the audience. Welcome, Sonia.
Thank you. Well, for me, this is the best kind of day ever, to be on the beautiful UBC campus, to spend a day talking about nursing history and to be in person to do that. And so for those of you who are online, we're glad you're here and you're missing out, both of those things. I just realized now that I don't get speaker notes the way that we're doing this. So I'm going to I know this stuff so well, maybe, that I'll just jump in. So my coming into this topic about public health nursing as a pandemic response in Canada, the USA, and China between 1919 and 1923 is China. And so, the last 20 years, what I've been studying is Canadian missionary nurses in China, and that's brought me backwards to be trying to look at the bigger questions, and what Esyllt said earlier, trying to connect the dots in some ways between the pandemic public health and the work that was going on in China. And so I'm going to be going through slides that give a really high level view of that has probably raised more questions for me than it's answered, but I hope it will raise some questions for you as well, to be making some what I think are very interesting connections between the Rockefellers and public health nursing education in Canada, and the start of UBC as well, UBC School of Nursing. So this is the timeline. This is the timeline that we're going to be spending time. Almost all of my time here is going to be on this, saying starting in 1899 all the way to 1923, there were some really important, for professional nursing and nursing education, some really significant highlights. We have starting with the USA connecting with the International Congress Council of Nurses in 1899, and then to 1923, when the Yale School of Nursing started its first baccalaureate degree. And I'm going to be walking through just how these are connected. So starting with the International Council of Nurses membership. So the US started in 1899. 10 years later, Canada joined the ICN. And then you look over to 1922 is when China joined the ICN. So those are sort of the time, important things going on in the world when the International Congress of Nurses, which is still, Council of Nurses, which is still running strong today, had the membership of Canada, the US, and China. Then there's, keeps jumping. Then there's the Nurses Associations. Now it's those of you who know the start of the Canadian Nursing Association and the American Nursing Association, these dates are a little misleading, because 1908 was Canada, 1911 was the USA, but of course I think it was 1893 that it was Canadian and US nurses together that started what became the separate nursing associations. But I find it really interesting as a Canadian to realize that right in between there was when China started its own nursing association. So there were some professional things going on in China at around this exact same time as in Canada and the USA. So from the US perspective, if they started the ICN in 1899, then in 1911 they started the American Nurses Association. And this, the degree, the baccalaureate degree in Yale was actually the second. The first one was at Columbia University, but for this topic, the Yale one becomes particularly important for reasons that you'll see in just a minute. So for Canada, or at least the Canada as a colony of Britain at the time. So you have in 1908, the Canadian Nurses Association, then it connected to the International Congress of Nurses. 1919, a UBC School of Nursing started, and then in 1920 was when the University of Toronto started its Department of Public Health. The University of Toronto didn't start its degree in nursing until a couple of decades later, but this was a really critical in terms of this my talk today. This was the more critical, probably even more critical than UBC. And then there's China. So China had 1909, it started its Nurses Association of China. In 1921, it started the elite school, the Peking Union Medical College in Beijing, which to this day is the most significant nursing school in the country. This was my book that was just published is really centered in on the PUMC in no small part because they were connected with the Canadian mission during the war of resistance against Japan. A Canadian mission in Jiangdu in West China actually hosted the Peking Union Medical College as a refugee university when Japan was occupying China. The PUMC traveled, migrated, really the dean and nursing faculty migrated over to West China. But this 1921 was a really important moment in the history of nursing, professional nursing in China. And then China, just 1 year later, joined the International Council of Nurses. They were kicked out, so to speak, in 1949 when the communists came to power, and China was just reinstated into the ICN about 5 or 6 years ago. And then there's the UBC, U of T, Peking Union, and Yale degrees. This is what becomes important. These are the important dates I want to point out to you: 1919, 1920, 1921, and 1923, all clustered around the same time. And the reason that this is important, where the real dividing line then is, of course, the Spanish flu, 1918 to 1919. And just as interesting to me as the Spanish flu is that these 3 degrees really had the full support of the Rockefeller Foundation, both in its funding and certainly in terms of the Peking Union Medical College. Was the Rockefeller Foundation did everything from building the institution to setting up fellowships where Chinese nurses could go abroad to Canada, to the US, or local nurses within the country could come to Beijing to further their education. So 1920, 1921, and 1923, you saw these first baccalaureate degrees, but then the question is, when you start seeing the Rockefeller connection, is to ask then, how is it that we have these first degrees, really, second one at Yale, but the first degrees in these 3 countries clustering all around the same time, including UBC in 1919. And so what led to this? Well, the big report that comes out, interestingly enough to me, in the Chinese documents was this a report that the Rockefeller Foundation convened in 1918, in part in response to the flu pandemic that was going on at the time. They said that they needed to do a survey, a national survey in the United States, conducted by Josephine Goldmark, who you see here, who was an activist, a union activist. And they said that the rationale for doing this big survey was that the public health nurse is an essential element in the development of public health throughout the world. And there is at present the widest divergence of opinion as to the proper training for this functionary. And it's generally felt that at present, no set of training courses is entirely satisfactory. So they set out this report, set out her to lead this in 1919. She took 4 years of studying over 70 programs in the United States and came up with this 1923 report, which has continued to be known as the Goldmark Report, which was a big impetus for these programs, whether it was the PUMC, whether it was the University of Toronto, whether it was Yale University, to really say that public health and public health nursing is essential to the care of the public in these three nations and well beyond. So this is the finding that then connects us to public health is this final report supported university education in nursing and said that the development and strengthening of university schools of nursing of a high grade, which really was a degree grade, for the training of leaders is of fundamental importance in the furtherance of nursing education. And Goldmark concluded that public health nursing could not be separated from general nursing, and thus public health nurses required preparation in both basic hospital training and public health nursing, which is why then we led to the idea of the degree here at UBC, 5-year degree that was combined with hospital nursing, and at University of Toronto too, their 4-year degree, and public health nursing has been incorporated into baccalaureate degrees here and previously in China and also in the United States ever since. So this is the conclusion of just a high level of connecting the dots. As the Rockefeller Foundation's response to the 1918 pandemic played an under-recognized role in the establishment of university level education for nurses in Canada and the USA and China. Thank you.
So nice how that works. I didn't check before, but I trusted IT. So welcome and thank you for coming. I'm really honored to be here all the way from Saskatchewan, fighting 2 snowstorms to get here. And really delighted to be back on campus in this beautiful building. I can't help but stare at all the molding. It's very beautiful. So the purpose of my brief presentation today is to discuss some of the overarching policy and public health developments that have influenced healthcare structures and public health nursing in Western Canada, to make some sense of the past and its influence on our current context. So to give some background in my current program of research, I've been working to better understand the history of hospitals in Western Canada, including a better understanding of both the diversity and funding of those hospitals. I've primarily focused my efforts on British Columbia and Saskatchewan because these are really important case studies in Canada's health history. British Columbia was the first province to consider provincial hospital funding, and Saskatchewan, of course, was the first to actually legislate it. In my work, I agree with previous scholars that have argued that it was colonization, industrialization, and urbanization that have transformed hospitals during the early 20th century from the former Victorian almshouse to a factory for the production of health. Over 80 hospitals were built in British Columbia alone from 1860 to 1918, but these hospitals were far from uniform, and a diverse array of hospital subtypes emerged, including Catholic, Protestant, municipal, provincial, private, Victoria Order of Nurses, Chinese, Japanese, Indian, and specialty hospitals. As a social historian, I've been interested in the social, political, and economic influences shaping these developments and these diversities. Historian Barry Doyle argues that health historians have tended to ignore the complexities of pre-war hospital provision to better support the argument that the move towards state-funded healthcare was a natural progression related to the emergence of modern welfare states. A more critical examination of these movements tells us much about how changes in policy and public health developments influences some of the healthcare crises that we see today. I think part of the reason I have focused on hospitals is because in the present, these institutions really represent the epicenters of nursing and medical care. But how did that happen? And what were the relationships between hospitals and public health, which led to hospitals dominating the healthcare landscape? In Canada, hospital and diagnostic care was not publicly funded on any grand scheme other than workers' compensation until the late 1940s. It would not be until the late 1960s when all citizens would receive hospital and physician care under the National Public Health System, otherwise known in Canada as Medicare. The movement towards these publicly funded structures actually happened in relation to several key influences. Our keynote, Esyllt, in her book Radical Medicine, points to several transnational influences, including the Soviet health center model, the British labor movement, the American New Deal. Canadian governments, though, have always played a role in the funding of healthcare services. In the early 20th century, hospital care was still very much tied to the idea of charity. But the story of hospital funding really begins with the British North American Act of 1867, which guided Confederation, and that act mandated the provinces to be responsible for hospital care in Canada. The earliest funding provided by the provinces were not organized in an equitable or stable manner. Hospitals in large centers tended to receive much more support from government than, for example, smaller religious hospitals. Many of the earliest Western Canadian hospitals were established by private nonprofit organizations and were operated through user subscription fee systems. During the 1870s, many provinces, Ontario being the first, passed a Charitable Aid Act, which would become the underlying policy for Canadian hospitals until the late 1940s. The Charity Aid Act standardized provincial grants to hospitals, often providing, for example, 20 cents per day for all admissions, then paying a reduced rate for patients staying over 120 days. Thus, governments actively encourage hospitals to house patients requiring acute care rather than chronic health services. This accelerated the transition from custodial care to short stay treatment model. So the funding policies really drove how the hospitals operated. Any hospitals which accepted provincial subsidies were required to operate on a nonprofit basis, which is how many provincial governments prevented a large number of private for-profit hospitals from operating in Canada. The Charitable Aid Acts were changed again in the mid-1880s to aim municipal funding at non-paying and partial paying patients. In other words, these municipal hospitals became responsible for charitable health funding for the working poor. By the 1920s and 30s, the provincial and municipal grants provided by the government, they provided close to 40% of hospital funding, and the province covered about 60% of those costs. Funds from paying patients and charitable donations were used to cover the rest of the costs. Patient fees in many provinces rose substantially during the Great Depression, often from about $1 a day to $3 or $4 a day. The history of hospital funding varied substantially between the provinces. Saskatchewan, for example, had some really unique policies that were quite different from provinces like Ontario, Quebec, and BC. In Saskatchewan, hospitals tended to be built and funded primarily by municipalities. As you can see in the picture here, one of the main policy differences was the Union Hospital Act of 1916. This act allowed small municipalities to join together to form a union such that they could construct and operate a hospital jointly, which led to lots of fights about where the hospital would be, but that's how it was. This legislation meant that Saskatchewan also eventually had the largest number of municipally managed hospitals in Canada. For example, by 1957, Saskatchewan had 119 municipal hospitals, Ontario 20, Quebec 2, Alberta 61, Manitoba 52, and BC only 2. Overall, the prairie provinces really tended to favor the operation of small municipal hospitals, while Ontario, Quebec, and BC tended to rely more on non-sectarian and religious hospitals. It was a severe effect of the Great Depression on the prairie, combined with reliance on these municipal hospitals and the election of Tommy Douglas's socialist CCF government, that really contributed to Saskatchewan being the first province to institute a one-payer provincial hospital insurance system by 1947, well known to be the precursor to Medicare. The primary aim being to ensure access to hospital care was free for citizens at the point of entry, but paid for through a provincial tax system. Other provinces quickly followed suit, and in 1962, Saskatchewan attempted to extend this to physician services, which was met with the doctors' strike, which garnered worldwide attention. The doctors eventually agreed to the new legislation, but only a fee-for-service payment structures were maintained, which helped them hold on to their autonomy and dominance in Canada's health care system as private practitioners. In 1966, Medicare was introduced by the federal government, though it was not until 1971 that all provinces officially had universal coverage for hospital and physician services. In 1984, the federal government introduced the Canadian Health Act, which essentially, I don't know why my slide keeps wanting to go forward, essentially ended the practice of charging citizens additional fees for particular services. I think it's important to note that this story is also a story of how healthcare funding was eventually aimed primarily towards hospitals, diagnostic and physician services. In other words, treatment-based services. Up until this time, public health departments had considerably more power and funding. During the early 1910s and 20s, there was a huge transformation in Canada's preventative health services, including major reforms focused on child health, school inspections, educational efforts about germs and hygiene. Public health nursing has vastly expanded as well, but there was a period of significant decline after the Great Depression. I really like to show this chart because it's very interesting to examine the organizational chart of the Saskatchewan Provincial Department of Public Health from 1931, because you can really see the differences in structure with major emphasis on infectious illness, sanitation, child health, public health nursing, and mental hygiene. Hospitals are buried in the division of child hygiene and in the division of sanitation. So during this time period, there was much greater emphasis on the structures of preventative medicine, which I like to point out to my students is very different from today's provincial organizational charts, which tend to focus on financing and human resources, taking nods from corporate structures. So in my classes, I like to put that up against present day and sort of talk about the differences. What is often overlooked or unknown by many of today's healthcare practitioners is that Saskatchewan's Premier, Tommy Douglas, often argued that Medicare was the first of two steps towards a sustainable future for healthcare in Canada. As Douglas writes in 1979, quote, "Those of us who talked about Medicare back in the 1940s, the 50s, and the 60s kept reminding the public there were two phases to Medicare. The first was to remove the financial barrier between those who provide healthcare services and those who need them. We pointed out repeatedly that this phase was the easiest of the problems we would confront. The phase number two would be much more difficult one, and that was to alter our delivery system to reduce costs and put emphasis on preventative medicine. Canadians can be proud of Medicare, but what we have to apply ourselves to now is that we have not yet grappled seriously with the second phase. For many health providers and policymakers, this second step envisioned by Douglas remains largely unknown, and most public debate now focuses on privatizing healthcare services." So to conclude, I have a couple of questions. I wonder if Canadians have contended with these shifts in healthcare funding and policy, which have really siphoned the funding towards hospital, diagnostic, and physician care. In my work, I found that preventative healthcare funding has been estimated at present to be somewhere between 1% and 5% of the overall health spending budget, which I am sure has compromised the role of public health nursing, particularly after the severe healthcare cuts of the 1990s. In Saskatchewan, many of my colleagues, public health nurses, are concerned about the changes they have experienced in their roles, often reduced to that of vaccination alone. I wonder that as societies re-examine health systems after the COVID crisis, will reformers pay attention to the history of the funding structures that have shaped the relationship between hospitals and public health services in Canada? I believe that understanding this history can provide a better foundation for our discussions and debates about healthcare in Canada. Thank you very much.
I'm going to move over here so I can see everyone in the room at least. Hello, everyone. And we're sticking it out. I don't know about you, but I feel like my head is so full of old ideas and new ideas. Anyway, so I'm Allison, and beside me in the shadows is Mariko, who, as Gertrude said, she's in Chicago right now, talking to another group of people about a different topic.
So my comments today really come from a conversation we have had. So, and I just want to say, so I kind of feel that weight a little bit. It's not just me here speaking. So I want to tell you just a little bit more about the two of us and how it is that you have two non-historians speaking to you at the end of today. It's important. So both of us do research in aging, but we have very much a community focus. And Mariko, much of her research has been inspired. She talks about being inspired by her clinical work. And as a researcher, she continues to maintain those ties to the clinical setting. And she has over 20 years of nursing experience with a real focus in community health and has worked in several roles in the community and really across the spectrum of care and home health. Her dissertation research looked at issues around transitions across different care settings, and we'll speak a little bit to that later. So my research interests are very similar to hers. I, in fact, had the great privilege of being her supervisor for her PhD. But unlike Mariko, I've not really held on to that kind of bedside practice. But as a researcher, I do engage very closely with older people in those places where they live. So in their homes, whether that be their traditional family home or in nursing homes, and in their communities. So as I said, we're not historians, but as nurses who spend a lot of time thinking about aging, we have been very grateful for this opportunity to consider Esyllt's paper in relation to the care of older people. So our comments are really going to be focused on what's happening here and now and how might we be looking forward, but linking with some of the ideas that we've heard expressed today. So our process was, we got together as part of the planning committee and had some conversation, but then the two of us met online a few days ago and had a conversation. I took a lot of notes, I've checked back in with her, and I'm hoping that today my comments are some reflection of that conversation. So really her ideas and my ideas together. So I want to begin by having us think about who nurses have been caring for through this pandemic over these last 3 years. So I suspect we're all aware of population aging. Since 2015, I believe, Canada has more seniors than children. And soon a full quarter of the population will be over age 65. And that segment of the population that's growing the fastest is people over age 85. And there's lots of reasons for that. And in part, it's the success really of the early public health measures that made it more possible for us to survive childhood. So that's the reality of nursing today. We know that the majority of hospitalized patients are older people, and likewise the majority of home care clients. And we know that through that first wave of COVID, Canada's long-term care homes was where people with COVID died. By the end of September 2020, 82% of all the COVID deaths in Canada had happened in our nursing homes. And we who are so proud of our Canadian healthcare system and often compare to our neighbors to the south, it's worth noting that that's more than twice the rate in the US. I believe that number was 37% of COVID deaths in the US were in nursing homes. I remember at the time, it seemed both hard to believe, and at the same time, I tried to think of what's the word, and what I came up with was I felt ashamed that I wasn't surprised at all. I recall hearing and using the metaphor myself of COVID having pulled back the curtain to see what we all knew, but hadn't wanted to recognize. Mariko and I talked a fair bit in our conversation about the idea of invisibility. Some of this comes, I think, from the work that we've been doing in our current research that we've been doing together in partnership with an action group of people living with dementia who have really helped us really understand the extent to which fear and stigma sits in all of us. It causes us to turn away and it drives the system. When we have organized ourselves around prevention and cure, an older person with dementia represents a failure. They don't fit, and it seems we don't want to talk about that. When Mariko and I met on Zoom, one of her very first comments as we started our conversation was, we just don't talk a lot about what happens in nursing homes and in home care. The face of pandemic nursing on the news every night was that of critical care, as you said. But in our neighborhoods, as we talked, in our neighborhoods, I think if we looked carefully, we might have seen something different. So I told Mariko a story while we were talking, and I'll share that here. So I remember being out for a walk around the park just across from my house during those early weeks of lockdown. It was that uncanny quiet. No sounds of airplanes, no cars in the street, no one about. And then I saw a nurse across the way getting supplies out of the trunk of her car and heading towards someone's home. And it was this strange kind of shock to see this community health nurse going about her work, visiting one of my neighbors. I'd never noticed it before. I told Mariko the story and she just nodded, saying, well, I don't remember her words, but it was kind of, well, yeah, of course. While I was out wandering the park, watching these home care nurses, she had been sitting at home working on the analysis for her dissertation research, and she had made the decision at that time that she needed to go back to work. So what I'll read next are her words. I went back to the recording last night because she tells the story well. So it's just a picture of what was happening in community health during those early months of COVID. She said, as soon as people who'd been hospitalized with COVID could be stabilized, this is in hospital, they were being sent home, many still testing positive, and even with symptoms. And there at home, they'd be supported by home care teams. Now, Mariko worked as a clinical educator, providing education for the new community health workers they were bringing in. And she described to me how they would be told, we don't have a lot of masks. You can go to your home office and you'll be given a certain amount. You can wear that mask as long as you don't take it off into multiple homes. If you take it off to take a drink or eat, you have to dispose of it. But if not, then go on the bus or take your car wearing the same mask. And she said, I remember thinking, I don't know how safe this is. There was a comment in one of our planning conversations, I remember sometime in the last month or so, and it might have been you, Ranjit, might have been Susan Duncan, I don't recall, but it is said, when public health is working well, we don't see it. And Mariko argues that the same might be said of the care that older people living at home received during the pandemic. Nurses were still coming into their homes. There was a lot of uncertainty, she said, a lot of strain. And as she said, they weren't really well prepared or well equipped, but the work carried on. Now, in our neighborhoods, the face of nursing was also in the long-term care homes who locked their doors to the families and friends, those people who in normal times provide a very significant portion of daily care. Nursing homes turned inward to do the very best they could with very little at hand. Not enough staff, not enough equipment, and not enough understanding or knowledge about infection prevention and control. It is true that in both pandemics, in 1918 and again in 2020, what was revealed was a lack of equitable access to care and inadequate resources. We know now that part of the COVID surge in Canada's long-term care homes happened not only because of resource deficiencies inside the homes, but also because decisions were being made outside the homes to protect the hospitals above all else. Alternate level of care, ALC, is a systems designation that's used to identify patients who no longer require acute care services, but who need something more, so they can't simply be sent home. And most often, this is because they need additional nursing care, but it's not the kind of nursing care that hospitals are designed for. So in the early days of the pandemic, large numbers of hospitalized older people were sent off to long-term care, so there would be hospital beds available for COVID patients. Now, of course, we know now, we knew then, that some of these older patients had COVID when they were moved. So that's how it happened, that's how it started. And even now, Mariko has pointed out, she's still doing some work with the health authorities. Planning right now is currently underway here in BC to move large numbers of ALC patients. Don't quote me on this. I think she said it's upwards of a half of those patients that are currently in hospital, the ALC patients, moving them out in the next few weeks to make room for the expected surge of COVID and flu and all the other things that are circulating in the coming months. So I hadn't told Mariko I was going to do this, but I must make reference to her dissertation research that focused on ALC. Nurses tend to do very little for these patients, and that's not because their needs are little. Their needs are in fact significant and very complex, but because their needs don't match up with what the place, the acute care hospital, is designed to offer. The hospital is reimbursed just really a mere token amount for ALC patients because the assumption is they don't require a lot of nursing time because they're just, to use her words, waiting for home. And yet there's insufficient care available at home. We're not funding that either. Mariko has written about how these patients exist in a kind of liminal space, and it is indeed a vulnerable space where they can be moved, often quite suddenly with little notice, to make room for those considered more worthy. So I'll really conclude our comments with some reference to the idea of where nurses provide care for older people. In gerontological nursing and social gerontology more broadly, the concept of the environment has always loomed large. And in these days, this shows up in the notion of aging in place. So when we're thinking about systems redesign and reconfiguring nursing care in relation to seniors' care, we might think of this as the Holy Grail. In short, it's the idea that people don't want to move as they get older. They want to stay in their own place. So of course, this means thinking differently about the built environment, how we design our homes, urban planning, how we build kind of public spaces. It means thinking differently about how we organize our neighborhoods as social spaces. And of course, it means organizing our healthcare systems differently to be better integrated in these communities. I took a particular note of Esyllt's comments about how nurses in the 1918 pandemic kind of blurred boundaries. It was a time of finding new roles in new places, and her discussion about the push for the all-in health centers in Saskatchewan after the war and the health cooperatives that were developed in the US under the auspices of the Farm Services Administration, was that it? It all seems very familiar to me. It really makes me think about how the field of aging care, we talk about the importance of integrated care and multidisciplinary teams. This is what we're always trying to strive towards. It's the very same thing. And in fact, this was very well established in BC's continuing care system from the 70s through the mid-90s. But like so much else at that time, it was quickly eroded and has never recovered. The idea of really how we've organized ourselves and continue to do so around acute care hospitals really just seems so antiquated to me. You know, it's like the balance seems off. I think that's a very polite way of putting it. So I was really so happy to accept this invitation to join the discussion today, because I too see hope in the idea of building forward from the pandemic to reframe public health, and I believe rethink the meaning of public health in relation to elder care. For too long, I would argue, older people have been excluded from our public health models, with its long history focusing on mothers and children. Or maybe I was thinking last night as I was kind of finishing up these notes, maybe for me, it's really the reverse. It's rethinking elder care in relation to this history of public health and how we think about that and how we might think about that moving forward. The continuing care system, that really is how we think about seniors' care outside, everything that's outside acute care, that continuing care system in aging care, I would argue, has long been very inward looking. We talk to each other. And it has not really so much seen itself as part of the broader community. So I find it really exciting to consider the possibilities of reframing public health around this idea of community and neighborhood level engagement. And it's precisely the same calls that are being made in aging care. So I think perhaps now could be a time to bring these two together in really interesting ways. Thank you.
Thank you so much, panel members. And maybe Esyllt, if you also would like to take a seat behind the table, then I stay here a bit. And somehow if you are able to share the mics, then we can actually open the discussion to each other as a panel members, to each other. You feel free to comment, and to the audience in the room. And we also monitor whether we have some questions in the Q&A box. So to open the discussion, maybe I would like to give Esyllt a chance, because we have, in some ways, by Sonia brought up the issue, if you call it that way, of nursing education, which I feel has also, you commented on it various times in terms of not only how we prepare, but the particular way nursing education has developed. And you mapped out the early link to academia that was so much promoted through the Rockefeller funds, because it was a requirement also within the funding structures to have the links to academic sites. But it has set a particular tone that resonates also with some debates today. And then Helen, you brought up the wider hospital structures in terms of what happened to them through Medicare or leading up to Medicare, and what resonated with Esyltt's comment around the increasing dominance of hospital-based care. And hospitals have also been the home that way for nursing and nursing education. So implications of that development is a true question, because it sort of, in some ways, dominates or has increasingly dominated attention to public health. And Alison, I would say thank you for bringing up the nursing practice in terms of going to the homes as a continuing theme in terms of nursing responsibilities, and how that also balances with you mentioned the tension between acute care institutions, long-term care, and there's so many questions that have never really disappeared, I would say. So before we move open to the audience, I thought, Esyllt, do you want to start a further commentary?
I don't know, can you hear me? Yeah, okay. Yeah, these were very interesting sets of thoughts. I'm just putting, trying to put some stuff together in my head. I mean, I'm a historian, so I'm always thinking about time, and why time is important and why it matters. And I think all of these papers illustrate, in a way, the critical nature of that period from the flu pandemic through at least the post-war development of Medicare. And it's so interesting how once you scratch the surface and you're looking for the pandemic, it sort of pops up where you didn't know it was. That's happened to me so many times, right? It makes perfect sense that there was a sort of response at the level of nursing education to the pandemic, but also it was, I think, building on, if you think about, the Margaret Scott mission and the fact that nurses who were being trained at the Winnipeg General were also being trained as community nurses, that there is this very significant shift is not as black and white as maybe we would think. So
there isn't necessarily the hospital here and public health here and home and community and neighborhood here. I think historically, at least, in that first half of the 20th century, they're much more closely interconnected than we tend to write about them being. And I don't know, I mean, because I'm a flu historian, I tend to use the flu to like ask anybody. I'm very guilty of this. I sort of use the pandemic to sort of like make sense of the world, which I realize has some fundamental flaws in it. But yeah, it's so interesting to think about rather than the separateness, the intersections between those, as Allison says, care settings, and how nurses are trained to be a part of those settings. And we're now maybe at this kind of high water mark of some sort of bifurcation, right? Like that, that needs to be addressed. I love that quote from Tommy Douglas from '79, because, with the 40s, that he has them backwards. Like the second phase was supposed to be hospitals, and yeah, the first phase was supposed to be at this kind of primary care delivery level. So interesting that would be there. But just one last thing. I was thinking, Allison, when I was listening to you talk about discussions, public health at the moment of the planning for Medicare, public health finds itself in a very weird place, right? And that's when the meaning of public health, all of a sudden public health is everything, right? And people who were writing about it in a way that is jarring from today's perspective. But they were speaking explicitly about the mortality transition, even in that period in the 60s, and speaking about public health needing to adapt to the care of people who had chronic illness and people who were elders. And I think there was some thinking about it, but I don't know where it goes. So I'd be interested in learning more about that.
Yeah, thank you. What about the question in the room? Is there a response or a thought that comes to mind that you would like? Yeah, please go to the microphone if you feel comfortable. What do you comment?
Yeah, oh my gosh, that's a great presentation today. I want to thank all of you, and I feel similar to Allison that it just seems like there's so much, my mind is full and my heart is full, and I'm reflecting on so many things. And so I think there's such a great opportunity for inspiration to action in the room. So, and I think about the statement that you made, Esyllt, about how the impact of nurses can easily be forgotten. And as a nurse in my life, just saying, hey, this is not new to nurses. We've had pandemics before. But my question to all of you is, what can we do to impact change? And I'm starting to think about answers, and I really feel like nurses' voices need to get to the decision makers and the power brokers, the politicians, the government. How do we do this? And I'm already thinking that now that there is a chief nursing officer appointed in Canada, how can we at this academic level, practice level, get a line in to communicate some of these things that we're observing? What are some suggestions that we can take away to effect change in our practice and wherever we have influence, and in our work and our choices, even career choices? Because I really feel like everything you're saying is such great information. The government needs to hear it. So ideas about what can we do? Thank you.
Okay, well, you asked a crucial question, Natalie, as to what can a nurse do. But I do think that it is a crucial question to ask. And I'm at the moment teaching the nurses coming in the first term of our program, where we also educate about relational practice. And one of our developers of the framework, Colleen Varco, taught of the relational inquiry framework, taught a guest lecture, but it was always bringing that question to the students. What can you do? And that can be basic, what we call basic, as to nurses are good listeners to start with. But what else, building on that and your question, Natalie, can we do? So I'm very pleased to give the word to the panel members, and who of you would like to share something that comes to mind as to what can we do?
Well, I think what comes to mind is it was mentioned twice here about the visibility. As when public health is being done well, we don't see it. And when you think of the even with the COVID pandemic, early on, it was nurses. It was we were clanging our pots and pans, and you know, at the time of shift change, and so there was like a moment where nurses were quite visible, and now it's become invisible again. So the voice and visibility are two ways in every possible way to do that. Marjorie McIntyre has in her book on related to you know, issues in nursing, does talk about advocacy for policy as an example. She has listed out everything from these are all just visibility ideas, from social media to letters to the members of parliament to an MLA to putting opinion pieces in the newspapers to writing and promoting books related to nursing, for just even you know, that there's one nurse, one memory about the pandemic, the flu pandemic, is just this one statue of this one nurse in the Maritimes. You know, so there is an opportunity to leverage this pandemic to go back and to say, how has nursing been behind the scenes in all of the other pandemics? So I would just say voice and visibility, and definitely to take advantage of the position of the chief nursing officer, because that is huge. We're so delighted that we finally have reinstated a chief nursing officer. So all of those things, I would say.
Thank you, Sonia. Is there any further comment immediately from either Helen or Alison? Or otherwise, I would say we go to the back of the room, because there was also still a question in the Q&A box that came up from already just when we left for our break. I would love to highlight it, Catherine, if you're able to, because it came from an international person in the audience who had the context of nursing in Germany, if he understood it well, and had a crucial question that I think has resonated in the panel responses as much as in Esyllt talk. So please state the question, and then we can see how we respond.
Yeah, so I think it was quite a similar question to what Natalie asked, and I think it really highlights that these questions aren't limited to Canadian nursing or the Canadian context, and that I think the question brings together these ideas that we've all been talking about of framing and conceptualizing public health, factors related to education, government and policy making, and practice, of course. So Veronica asked us, what would you recommend where to start nowadays implementing public health nursing? We don't have established public health nursing in Germany. Sorry, I'm going to go off. Nor many public health nurses. And we have mostly physician-dominated health services.
Who would like to comment? Because it to me, it resonated with this tension between, on the one hand, the desire to have public health and focused on public prevention versus the power and the dominance, what came through in some of the commentaries of the medical, which I would implies more biomedical treatment-oriented service. And is there a way to negotiate or to navigate in some ways which came through in some of the developments of public health in Canada as well. Yeah, please.
I'm a little hesitant because the thoughts are not fully formed, but in my thinking, I think we get held back because being invisible is a very safe place to be. And so I will be speaking as someone who's kind of in aging care. It's a safe place to go. Everyone knows it's important. No one really wants to do it, and you can kind of, when I say it, it's like a safe place to be. The risk then becomes that we become quite inward-looking, that we're very responsive to context. Often feel that we don't get the, and so we can be public health nurses, it can be, gerontological nurses, we don't get the respect we deserve. People don't really see the work that we do. So in terms of what we can do, what we need to do is kind of look beyond those boxes that we put ourselves in, pull the curtains aside and look out and say, what we're doing is it actually needs to be different. The system actually needs to be different. And I guess when I hear historians talk, and I realize, because it's not ancient history either, right? Oh, we could do it differently. We've got this health insurance scheme and it's been sitting around for 60 years. It's time to shake it up. And I was commenting to someone, I don't remember who, or for lunch, like the loss of public trust is actually perhaps an opportunity that maybe we might have some reception, some people to listen to those voices, because everyone, we know this is not sustainable. Yeah, like Tommy Douglas really did get it wrong. Like, what is this idea you build a hospital system and then try to figure out how to contain costs so you could do this other thing? And it's like, give me a break, Anyway.
Do you want to comment on it, Helen?
Well, just that I think, for me, I've been really following the money. And I noticed that as I follow the money drives a lot of the structures. So the policy is what drives the funding. So it's sort of that old thing, like nurses need to be more politically active. They need to, and I think too, Medicare is associated with being Canadian. Like it's almost a value. It's not just a policy, it's a value. And so people don't want to touch it. But by not understanding where it came from, all the reiterations that happened before it actually became a policy, you miss out on the fact that it wasn't what it was meant to be. And then that it actually, people had better ideas, I think, than what actually happened. And what happened was stifled in some ways by some of the politics of the time. And because it's like, Canadians really appreciated it, they liked it, especially at the time it was so important, and it's become this Canadian value, people are really hesitant to touch it. Like it's kind of known as an untouchable sort of policy discussion to have today, because they know Canadians will turf any government that tries to touch it. But so then we have to go back to the public and say, actually, let's look at this. And I think one of the problems is the way that we talk about public health care in general, and that it always goes to, well, we need to privatize, that's the only solution. And it's ridiculous for me as a historian, because our system has always been a mixture of charity, public funding, and some private things as well. And so if you reconstruct these debates, I think you might open up some windows for change.
Thank you. Do we have other questions from our audience in the Q&A box? And we have a question in the room as well, so please go ahead, and then we do the question in the room and then follow the one from the Q&A box. Yeah.
Can you hear me? So I'm now a retired nurse. First half of my nursing was in perinatal nursing, and then public health, and then public health nurse educator. One of the more exciting times when I think about ancillary voice and power was when in the 90s and early 2000s, we got the Community Health Nurses Association of Canada, as it was known then, SHNAC, and now CHNC. And for myself, I belong to, I participated at the board level, and I, today, I wonder if naming ourselves as community health nurses, that broader umbrella rather than public health, might that bring us back to place where we give health inside the community and we care for the community with the community. In nursing education, it was becoming more difficult to get clinical practice areas that actually allowed students to learn about community, because public health nursing had become siloed. And, as an educator, I just went outside of public health to find organizations that would take my students so that they could learn how communities maintain their health, promote their health. I don't want to get off onto nursing education, but I just kept listening today and thinking about the term community health nursing might be helpful. And when I think about using our voices, to remember CHNC actually has the ear of the federal government. They're a good voice. They're listened to. After SARS, we got PHAC, we, under Dr. David Butler, we actually really moved along. And then the organizational structure has changed. And I'm feeling a weakness there for nursing that we had in the beginning.
Very good. If I pick the particular point you brought up as to the naming, whether that would make a difference. Would there be any response from the panel as to, because we have gone back and forth from community, public health, primary health care. We had a conversation about primary clinics, which is now a buzzword into the development, as to they represent different kinds of values. What are the thoughts on community? Alison?
This is Mariko talking.
Okay.
She said, so she's working in community health, and she said, our teams are disappearing. People are leaving. The nurses are going to the new primary care units. She said, and what is that all about? Like, is that like, that's kind of different. And yeah, anyway, it came up in our conversation.
Very good point. What is the question from our Q&A member? And then I see Ranjit might have.
Yeah, well, sure, yeah. Well, not that it's super insightful, just more is interesting that you introduced me and I introduced myself as a public health nurse. And it's on my CV as a public health nurse, but in fact, I was a community health nurse when I graduated, and that's what we were calling ourselves, both in, when I worked in as in outpost nursing, I was a community health nurse, and when I worked in Calgary, community health nurse in Lethbridge. So those were all in the late 80s and early 90s, and so I was happy when we switched over to the wording of public health nursing. Also taught community health nursing because the public has a clearer idea of what that term means. It's almost community health almost too broad to understand. So that is the tension between something focused enough that gets the communities has at least a basic understanding to something that allows us, as you're saying, to move around a little bit more and maybe have a bit more leverage. But yeah, so I call myself a former public health nurse, but I really was a former community health nurse, formally.
Yeah.
This is not a question, more of an observation. I think that's a great suggestion. I don't know how it is that we could change the title back to community health nursing, but I was in a meeting with nurse practitioners and BSN educators, and we were trying to see how we could get undergrad students to possibly going to primary health care clinics to get some practice with nurses in primary care clinics. And the BSN educators were asking, what is a primary health care? What is your primary health care clinic? Because the conceptualization of what a primary health care clinic from a nurse practitioner perspective versus an undergrad nurse perspective is so different. So these terminology, we're all in nursing, but we all don't know what each other does. And I think it was such a great point to say community, because it's true.
when the patients get discharged, they're still not ready to be independent, and there is responsibility passed to the community to continue the care. So it's really a good idea, I think, and I'm supporting that, to differentiate and call community versus public, because I think that gives a better sense of it's our responsibility, and it's not just one part of the community, it's all parts of the community.
Very good point. Okay, so now I need to bring in some order here, because I had promised to address a question from the Q&A box, and I also see it's almost close to 1. So we have competing demands here, but I do want to value the commitment to our virtual audience. So please share the question from the Q&A.
Okay, so this question and comment comes from Susan Duncan. And she says, thank you for these critical insights. To the question of nursing influence during this time of medicalization of many aspects of our care and systems, including nursing education, I think about the historic advocacy of professional associations in nursing in influencing a vision and role of public health nursing and nursing and health systems, and the contrast to today when our professional associations are not as visible or as supported. Do you think that our loss of a collective advocacy movement within nursing is influencing directions today? And what might replace this in current times? And then she says in brackets, it's just a small question.
Well, that is another layer we haven't perhaps talked so much about in terms of how we organize ourselves if we want to influence, and how we have been organized. And BC is known for a lot of change in nurse organization over the last decades, I would say. Any thoughts? And I have to look now to the nurses in the panel. In terms of a response to Susan Duncan's question around advocacy through nursing organization. Esyllt has an idea.
Oh, well, just because it's a chance for me to talk about something I didn't mention, which is in the 90s, for 4 years, I worked for the Manitoba Nurses Union as their researcher. This is before I did my PhD. And the 90s were, just a very difficult time. That was when Manitoba one day woke up to find the health minister had eliminated the LPN category from the face of the earth, which resulted in, 300, nearly 400 women losing their jobs. But at that time, MNU was committed to the kind of advocacy that you're talking about. So they worked hard to present a proactive vision for nursing. And I remember some of the work that we did. I remember in particular, the communications person at MNU at that time was very, very gifted, and we did like a kind of an infomercial, a mini documentary, and the different nurses that were interviewed there. And I remember the public health nurses who were very active in the union. The public health nurses local was very active. There was a public health nurse, there was a home care nurse, there were palliative care nurses that were interviewed in this video, in addition to nurses working in acute care roles as well, or tertiary roles. So I think it's possible to, I don't know how much advocacy of that kind nursing unions in Canada are doing at the moment, but there's a capacity there, I think, to not to have a broader kind of role in advocating for a different kind of health system, not just sort of bread and butter union issues. Anyway.
Maybe, Gertrude, what I'd add to that is the pooling of nursing groups. So you talk about the union. We have a number of provincial and national groups, from the Canadian Nurses Association, the Canadian Association for Schools of Nursing, the national union levels, as well as Public Health Association, the Canadian Indigenous Nurses Association, bringing these groups around together towards it's helpful if there's a specific issue to be tackling, and the Canadian, the chief nursing officer, I think, is a really good example of that. There were a number of different groups that were advocating for that at the same time. So maybe it's also not seeing ourselves as associations or the college regulators or the unions, but to be seeing ourselves collectively as nurses, especially nationally, and pooling toward showing ourselves and each other what can be done when we actually see ourselves as working together in the same direction and not just on our individual areas.
I would also underline both aspects bringing up as to how organizations can have influence, but also how networking between and collaborating between, actually, when you think about it, in how many ways nurses are organized, whether it is in the domain of public health, or whether it is in the educational domain or the national professional organizations. I do think that you bring up as to how we can work together to strengthen the voice of nurses. And I am also very pleased we have the chief nursing officer now, as to also having that more stronger political presence. So I think it's a good note to end our conversation. And I cannot say how thankful I am for all that you contributed in terms of our influencing our minds and giving ideas as to ponder as to how we can address the many problems that continue to mark healthcare, and that our students, as well as our citizens using healthcare, experience on a daily basis. So thank you very much. I would say I say a few closing remarks, and then we give our panel a big applause thereafter. Thank you all for contributing to this valuable discussion. And before I close the discussion, I would like to make a few more important acknowledgements and thank yous. I would like to acknowledge the help we have received from the staff at the UBC School of Nursing, particularly Heather Swallow, the school web and communication manager, Marilee Hughes, Research Grants and Knowledge Translation Manager, and Alan Siu, for their, who is the financial manager, for their continued support in organizing the symposium. Your creativity and commitment is invaluable. Also in the virtual background, Catherine Haney and Margaret Skaya, who have worked together with the AV service. Thank you for support in managing, and thank you for the groups who came to present the materials in the solarium and this being in this beautiful place. Thanks a lot. Catherine, especially also for your help in attending all the details to make the symposium a smoothly organized experience for today. And we really couldn't have done without you. And then last but not least, a tremendous thank you for our keynote speaker, Esyllt Jones. I have something for all of you, so can you have it? And also for Sonia and Alan, and Alison gets two. Alison has two people. And we really could, want to sort of say thank you for your engaging discussion, and really reflect on the social and cultural meaning of you know, what the pandemic has meant over time. And so I would say thank you for filling our minds with ideas to reflect on. And please give our panel a big applause.